Hi, morning, Theo. So I think I'll quickly carry on the cases thing. So today I'll be presenting on Mr. L. We have here a 44-year-old Indian gentleman who has been diagnosed with ESRF since 1996, quite a long time. And he even had a cadaveric transplant in 2011, which unfortunately failed a year later due to recurrent urosepsis. His other comorbids includes chronic Hep C, which has already been treated, and also having a CKD mineral bone disease. He had previously had a bilateral neck exploration and total parathyroidectomy done in 2009. And at that point of time, there was no organ transplantation done. This was done, I think, around 2 years before his cadaveric transplant. Other significant histories would include that he actually had a right AKA done due to MVA, and it's actually a very motivated patient. He's on prosthesis and is able to ambulate well. And subsequently, in 2022, 2 years ago, he actually had a left hip bipolar hemiarthroplasty due to femoral head osteomyelitis. Unfortunately, due to it being an infected area, he was actually complicated with prosthetic joint infection requiring stage revision surgery. His first stage revision surgery was done, but if you look at the X-ray, we can see that his bone is actually severely osteoporotic, and the orthopedics are actually quite worried about it and decided to refer to us. So the reason they refer to us is because they are planning for a second stage revision, and they need to do a total hip replacement. But his bone was very bad. Intraoperatively, they can see it with the X-rays, and even with the bloods also, it's not very beautiful. If you look at it, the IPTH is raised despite the total parathyroidectomy done many years ago. And the serum calcium is all right, it's normal, but the serum phosphate is high, and the serum ALP also is on the higher side despite optimizing his medication. Clinically, he has a very well-healed scar. There's actually no mass or purple in the neck. So I guess the first question now is, at this point, what would be his diagnosis? Anyone? Can we just... Oh, I think just now, where did we stop? Can we just carry on? Yeah.
I think the patient is having renal hyperparathyroidism. Recurrent renal hyperparathyroidism.
Right. Okay. And what would be the possible cause? He had a surgery done before. He had it removed.
So this patient has a total parathyroid done before.
Right.
Okay, and the transplant is failed.
Yes.
So at this point, because the PTH is high, then the calcium also high. So I was thinking that maybe he has recurrent of the hyperparathyroidism secondary to maybe incomplete removal of the previous parathyroid gland, or he has a pulmonary parathyroid.
Yeah, I guess in the interest of time, we just move on. That's correct. Yeah, he does has a recurrent renal hyperparathyroidism, and there are multiple causes. Could be due to a missed or incomplete removal of the parathyroid gland. Could be maybe the patient does has a supernary parathyroid gland, or it could be just parathyroidomatosis. Maybe in the first surgery just broken up and now it's just coming back. So the indication for referral is that, right, he has a recurrent renal hyperparathyroidism, and the orthopedic needs to do their surgery. He has a chronic kidney disease, mineral and bone disorder, and we need to help to improve the bone mineral density. So what will you do next? Can we move on to the next? Right.
So before you localize, what information you want? Do you think the information is already complete? You are happy to go in with the surgery? previous parathyroidectomy one.
whether everything should be fine, it should be as well. And then,
So what information you want?
whether, all the form that have been done, is it complete?
So
Whether
how you obtain that information?
from the previous, those HP results.
15 years ago. 15 years ago.
Or we can ask patient history and not with the previous, patient, in so patient, they might have the under follow-up and view and
If you want to trace the laws, to get the HP, right? Anything else? How do you know that the patient has not any local transplantation?
because he's mentioned during the
How do you know about it?
instance, because,
Anything that you can do to confirm whether Dr. Thompson was done or not? Have you done any local transplantation? When normally is that? Okay, so you can see a scar, right? If it's not done in the forearm, any other place, right? So how do you know? How you ascertain that?
By scan,
You can do a scan to see any hypocoagulation in the sternocleidomastoid. Anything else?
and then this is the scan.
No, you can do an X-ray, right? You can see sometimes we use a clip, right? Whenever we do our transplantation, we put a clip, right?
Sorry, sir, in this case, would it be possible in the sternocleidomastoid? Is it possible? I don't know, I'm asking.
Usually we do transplant at brachioradialis.
Why?
Because later in future, if patient develop like IPH keep on increasing, yeah, like recurrence and thing easier for localization, can because of test.
When would you do auto transplant in the sternocleidomastoid?
Usually, if we do total thyroidectomy and we accidentally cut or remove the parathyroid, then we can auto transplant at the
If the parathyroid is normal,
yes.
you tak perlu nak explore dah. Jadi kat transplant kat sini, so tak payah nak tengok lagi.
Right. So yeah, the things we do, we have to trace the all HPE and op nodes. And another thing would be to do a pre-op localization of this said offending lesion. And as we mentioned, unfortunately, it's 15 years ago, whatever HPE nodes is no longer available. Patient was discharged to the private center for dialysis. So even the nephro doesn't have the nodes also, right? This was a new referral back. And we actually did our own ultrasound, bedside ultrasound on top of a formal ultrasound sent to the radiologist. And unfortunately, we were also unable to visualize any parathyroid glands. So at this point of time, any other imagings that you'll be looking for?
I'd like to do a systemic scan to localize.
Right. So actually, yeah, systemic scan dual tracer was actually done a few times because the raise in his IBDH and all the blood parameters wasn't a recent thing. It's been there for a few years, and in total they actually done 3 systemic scans. The first 2 done in 2019, they can't really pick up any evidence of any functioning parathyroid adenoma. Fortunately, on the third one, when they did it in 2022, due to the persistently raised blood parameters, they were able to see something. So, right. Anybody wants to attempt to have a look at the system scan?
Both the mic.
This is at start 30 minutes and also 3 hours. 30 minutes and 3 hours.
That's not really.
Subsequently, there are other protocols. Yeah, after that, we have suppression scans. So here we move on. Actually, this SWV static scan isn't very revealing. There's nothing much there. So we have our SWV suppression protocol.
Suppression, I think something at the left side.
Yeah.
Period.
Let period, yes. So we have a protective texting, the phase 30 minutes, SWV phase, SWV 30 minutes, and also suppression. You can see something, the faint uptake here. So we also did a spec, SWV spec and CT fusion. So anyone want to try to take a look?
Compared to the previous diabetes, and it's also at the part is the other image actually image.
So actually the reason we put up this scan is because actually from the even on the spec and CT fusion, the parathyroid glands are actually not very well visible. Actually, whatever we are seeing here, this uptake is actually by the thyroid, right? The parathyroid is actually very small at the side there. Similarly, if you look at this, it looks like as if the whole uptake is there, but that's actually your thyroid. Because it's a sesame B, the uptake is actually by our thyroid and also our parathyroid. So it's actually very small down here. So technically, when they reported, it's actually just a very faint uptake in our SPEC CT and CT fusion. So our question will be, are there any other preoperative localization modalities? Right. Yeah, I think I'll move on in the interest of time.
It's 9 o'clock.
Yeah. So I think this was mentioned yesterday in the previous case discussion. These are the other available preoperative localization modalities for the CT, MRI, PET-CT, and selective venous sampling. I think selective venous sampling can be used if you want to confirm whether there's a location of it. Unfortunately, PET-CT, we don't have it in Malaysia because of the radial tracer is not available. But our HKL nuclear team is trying to talk to the IKN to see whether they can create a radial tracer later on, right? And this one is just interesting just to put it out because if you look at it, the ultrasound also actually have a very high sensitivity when it's done by an expert hand. And in fact, it's pretty good when you add on with SESTA-BP, the sensitivity can go as high as 95%. It's also good because the surgeon can also use it intraoperatively to localize it. So the summary so far, right, this patient actually has recurrent hyperparathyroidism, severe CKD mineral bone disease, and he actually has a faint uptake on the SESTA-BP SPECT-CT fusion scanner. So next question is, should we do the surgery? And what are the checklists for the surgery?
So I think there is indication for this patient to be because of the hyperparathyroidism at the bone. Checklist for the surgery. So of course we need to make sure that the patient is fit for the surgery. He has underlying renal problem. So he probably has other comorbidities as well.
It's fit for surgery. Yes.
Fit for surgery. So anesthetics, and then
All that been done already.
so in a patient with a such advanced osteoporosis, ALP was high. The concern is post-operative patient is high risk.
Say you are planning to do surgery. You're planning to do surgery. What is your plan?
Oh, so for the surgery itself, I think we have to, based on the imaging, the localization, we can try to do a minimally invasive unilateral exploration and also intraoperative PTH, focusing on the left side, left inferior, and then if we found the parathyroid gland with a reduced IOPH.
So you want to do minimally invasive.
With IOPTH first, because it is a reduced surgery.
Bear in mind that we have not localized the parathyroid.
Oh,
The imaging that we have is not like 100% sure is parathyroid at all.
I see. So
You know, this is a reduced surgery.
yeah. So I think before we especially in redo cases, I think we should try to localize as much as possible. If we can't,
It's all done already.
the sampling smaller.
Okay, something we don't do that.
Okay.
So
So in
it's
case,
everything done already. The imaging is already done. You're not going to need any imaging to localize it. Right?
so that means biological exploration away surgery, so the risk is higher.
No biological exploration.
So the risk is higher. So if not, we have another indication now. Yeah, so the research is multiplication side.
Thank you. So yeah, so this yes, we will do the indications for recurrence. So with osteoporotic bone, and the scan findings they are seen, but it's very faint.
Hello. Okay, quite careful when you answer questions. When you exam, you answer questions based on cases, bukan general, right? So bila kau jawab macam ni, IOPTH, macam mana nak buat IOPTH kalau renal failure? We do it in renal failure? Because we don't know the expression, right? So careful when you answer this question, macam ni. Nanti you miss out, right?
Right. So there will also be usage of intraoperative assessment tool. So this would be our checklist. First we have to do IONM because it's a reduced surgery, high risk of nerve injury. And we need to know beforehand where are the places that we need to explore. And we have that from our pre-operative localization and also the expected area of where we want to explore the missed gland, the ectopic glands. I have a picture here which is have the common areas. And yeah, I think sorry, intraoperative IPA. Yes, actually there's this issue because the ESRF they have a poor excretion, right? There will be an increase from the common usually 3 to 5 minutes to around 6 to 7 minutes. But I think a few reasons. There are also studies that really showed that it is the false negative rate for IOPTH in the ESR patient is only around 5 to 6%. And this our IOPTH is actually an adjunct to another methods they were using to assess the parathyroid intraoperatively.
Is this all you prepared for the op? Anything else?
There was basically. Still got.
Still got show us.
Yeah. And we also have to counsel the patient of a possibility of a hemithyrectomy if the parathyroid cannot be identified. So
Any more? Any more material to prepare the
Yeah, to prepare what else we need for like the question was, what if we still can't find it intraop? Is there any other ways to increase our possibility of localizing intraoperatively? And we have here multiple methods that's available for intraoperative assessment. As I mentioned, we need additional intraoperative assessment tool to help us localize it intraoperatively. And these are a few methods. We have the radio-guided parathyroidectomy, that will be the gamma probe. And we have the indocyanine grid, the near-infrared fluorescence. We have the carbon nanoparticles that's recently available. And our IOPTH, which helps to confirm that we actually removed the parathyroid gland.
Is there any way else to confirm that you removed parathyroid?
There one mentioned before this was the IOPTH, but I think that's
Anything else? Sebab dah tak buat dah sekarang kan? What time to buat?
and
Just ask pula. You need any other method to do whether it is a parathyroid?
we can try to aspirate the state lesion and send the FNSC to see whether we can get the PTH assay from it to confirm.
Have you got frozen section?
Yes, and also frozen section.
Yeah, I think that is cheaper and simpler, provided you need to have a good pathologist. Because sometimes during re-expression, you have to start removing everything. Timers, everything you remove.
Yep.
So the PTH may not be very, very accurate. That's number one. When you start to present the good dalam leher tu, you disrupted a lot of blood supply. So PTH may go down, but you actually did not remove the gland at all. So I think you should think the whole method of doing frozen section.
So I mean, like Miss Aina said, last time we go frozen section, then we noticed that sending a frozen section is taking a lot of time. So we stopped doing it, right? So now we are identifying the parathyroid by slicing the parathyroid, right? So normally you see a homogeneous and brown structures, right? But the question is if you can find it. If you cannot find it, that is the issue, right? So in this case, we cannot localizing it, right? And then we always have to prepare if we cannot find it, right? So anything else that we can actually do for increase the chances of us identifying the parathyroid. So this is the dilemma that we have for this case.
I cannot help but to ask you question.
Yeah.
You did mention about kalau tak jumpa apa-apa, you nak buat hemipteroidectomy. Betul?
Yeah.
Which part? Left ke right?
I think
Because nothing evidence nowhere.
Yeah.
So you nak buat apa?
I think this one is in conjunction for this patient because there was a faint uptake at the left inferior lobe. So that's the area that we were thinking it could be at. Of course, we will have to proceed with a full bilateral neck exploration. We have to explore areas that we expect a atopic parathyroid. I think previously we have set up this diagram to tell that this is our preoperatively. We need to have our plan, our map to know where we want to explore in case we really don't see the parathyroid at the area that the cesta maybe has an uptake.
So you do hemi because you takut intrathyroidal, betul?
Yeah.
So you must ascertain dalam thyroid tu ada something. Kalau you pergi buat ultrasound, then you have to do an ultrasound lah. Make sure tak ada apa. There is a nodule there. Kalau you pergi buang je, what's the point? Right? Okay. And then one of the most important, I give a talk last time in MBSC, ASAS, with regards to the imaging for parathyroid. None of these parathyroid assessment imaging has a good sensitivity, right?
Yes.
But what I think is the most important is either CT scan, MRI, PET ni semua. Bukan saja kita nak tahu where is the remaining parathyroid. It's important to know whether it's intrathoracic. if you're able to exclude there is no intrathoracic component, then you can explore. Tapi nak dalam chest tu kena make sure lah tak ada apa-apa. Right?
Yes.
Okay.
So yeah, eventually what we did, we actually did a left neck exploration with gamma guidance and IPTH, interpretive intact PTH, and also nerve monitoring. So for our interpretive finding, we actually found a left inferior parathyroid gland. It's very small. It's actually not very visible. Later I'll show the picture and video. And we had to actually localize it using the gamma probe. And usually for the gamma probe, we will have to take a background reading, and we have to repeat the reading of the suspicious gland ex vivo, and to make sure there's actually a 20% increase compared to the background reading before we can confirm that this is the offending gland. Post-op, the removal background, despite our removal of the offending gland, the reading is still quite high, but this is expected because patient has ESRF. The excretion of the radial tracer will be as fast. You expect it to have the retention. So this is also a reason why we were using IOPTH, because it was used in adjunct to this to confirm whether or not we managed to remove it. Usually the gamma probe comes, you have to do it together with IOPTH. So the background reading, we have it done at the isthmus, it's 7,800. We have to inject the tracer 60 to 90 minutes before. The surgery has to be done within that time period of time. And this is the, if you look at it, I have to stop it for a while. Right, so if you look at it, we really can't see the parathyroid gland one. Right, we actually had to use the gamma probe to slowly localize where is it. And we confirm it by the reading. That reading was 11,000. The background reading was around 7,000 plus, 7,008, right? So this is our PTH reading. Our pre-incision was 5, pre-excision was 2, and our post, syndrome. So the HPE confirmed, it's a parathyroid hyperplasia.
So in this case, Alhamdulillah actually identified the parathyroid. So the gamma probe is the one that helps me to localize the parathyroid.
Right, thank you, Dr. Koh and Ms. Rafi. So basically,